Olá a todos do TMOCast, eu sou Juliana Dallagnol, sou médica hematologista do Hospital Israelita Albert Einstein e hoje estou acompanhada de dois grandes nomes da leucemia mieloide aguda, professor Marcos de Lima, da Universidade de Ohio, e professor Sérgio Geralt, do Memorial Sloan Kettering. E vamos conversar sobre pacientes com leucemia mieloide aguda que não estão em remissão e precisam ir para o transplante de medula óssea. Como devemos fazer? Vou trocar a língua agora para o inglês para que a gente possa ter essa conversa de forma mais natural. So, Professor Geralt, we have a lecture couple of minutes before, and we are talking about some ways to improve the patients who are not remission and have a better outcome in transplant. So what is the, you expose some important trials, some of them we don't have in Brazil, some we can do in Brazil. So maybe you can talk about improve the conditional regimen for this patient.
So I think, Juliana, thank you so much for inviting us to do this podcast. As we discussed, and Marcos and I have been on this voyage for now more than 20 years. The first order of business is rapid referral. The best way of getting a patient to transplant in remission is getting to transplant quickly. But in the event that the patient is not in remission, we do think that transplant can make a significant difference because it is the only strategy that will get them in remission. Further chemotherapy just deteriorates the patients and delays the process. And then once we decide to do the transplant, optimizing the conditioning regimen is the first step. Marcos was instrumental in developing IV busulfan, and we show that personalized busulfan actually makes a difference. It's the adequate exposure. Many centers don't have busulfan pharmacokinetics, but there's actually a population PK model that with certain variables you can try to optimize busulfan exposure. Marrow irradiation is another one. TBI is very important. Total marrow irradiation, available in some places in Brazil, also is available. And I think these patients, even with optimized conditioning, have a very high risk of relapse, and some form of post-transplant maintenance with cells and drugs are important. I'll see what Marcos has to say.
Sergio, you had a slide that sort of separated transplant steps in before, during, and after. And I think if you think like that, if you break it a little bit, I think the one study that I would conduct in Brazil if I were here would be the low dose prophylactic DLI. We know that access to expensive target drugs is very limited. Some of them are $30,000 a month. So it's unrealistic to say, well, I want a FLT3 inhibitor maintenance. Well, you can't. But it's quite possible that the approach that was discussed during the conversation today of giving low doses of DLI while the patient is on cyclosporine or tacrolimus may be a feasible approach very early on. Então, if I were here, you asked us before the podcast about potential studies, that would be one that I would think that's very possible. And the pediatricians are already doing it, right? The Brazilian pediatricians are already doing it. So it's a matter of thinking of adults as well.
Yes. And how about the myeloablative conditional for patients who can do? So there is any special conditional for this patient?
So what's interesting is there have been a couple of retrospective analysis of people with active disease. And in some of them, conditioning intensity makes a difference. I don't think radiation therapy itself, but optimizing busulfan, and actually Dr. Freeman also showed data that for patients with acute myeloid leukemia, with MRD positivity, high melphalan as opposed to low dose busulfan is also a more optimal regimen. We will hopefully be presenting at ASH this year. We've been working on trying to find a optimized melphalan exposure for the fludarabine melphalan regimen. So I think there is a way again of trying to optimize drug exposure as a very straightforward way of improving outcomes.
It's interesting that you mentioned that, because if you look at the measure study, which was sort of a retrospective study looking at several samples of patients treated in multiple institutions in the United States and look at the MRD and the interaction between pre-transplant MRD and preparative regimens. Fludarabine melphalan did the best. So conversely, all other regimens, especially of reduced intensity, did way worse. And these were patients who were in hematologic remission but had MRD. So that's very much an important consideration. Not all regimens are the same.
And I think Marcos makes a good point, is that we talk about active disease and we made specific comment in people who had morphologic active disease. But we know now that patients who are MRD positive still have a very high risk of relapse and should be considered for some form of post-transplant intervention to reduce that risk of relapse.
And in routine, you are looking for MRD monthly and chimerism?
You have to look every 3 months is what we're doing.
Okay.
We do look at monthly chimerisms, although
Okay.
again, in resources constrained places, that's not possible. So I think every 3 months makes a difference. Dr. Freeman had shown that there is about 2 to 3 months between MRD positivity and fluoride relapse. So 3 months makes sense.
Okay.
So I would add that it's absolutely important to have these tests post-transplant. However, for AML especially, it's very much well known and has been for many years that you can absolutely predict. You showed several models that they are not fancy. If you have blasts before transplants, I don't have to know this person's MRD after transplant, because even if they are MRD negative, their chance of relapse is still huge. So I think the models are very much based on relatively simple characteristics. And if I know by any measurement that MRD before transplant is present, it almost does not matter if they are in remission after transplant, because the risk is still there. My second comment on this would be also that some of the molecular, for example, IDH1 versus FLT3 and NPM1, they are not made the same. One of the things that came out of this measured study is that IDH1 and 2 are very poor predictors. If you have those markers before transplant, they are not exactly associated as much bad prognosis as FLT3 and NPM1. So you can get away probably by testing NPM1, FLT3. And finally, my comment about chimerism. We should remember that chimerism tests are very poor. They have very poor sensitivity, right? They are probably 1 in 10, maybe 5%. And if they are 100%, they don't exclude presence of autologous hematopoiesis at a very high level. So it gives you sometimes a false sense of security. That's my view about chimerism with the tests that we usually do.
Okay. And in Brazil, sometimes you do a lot of off-label prescriptions, so it's very common to try to improve the outcome of the patient and maybe do some off-label kind of treatment, like maintenance with VAN, with hypomethylate agents, but we don't have any data, so
there is a lot of data now with hypomethylating agents post-transplant. And again, I use them off protocol and off label frequently because there's safety data. We know we can do it. There will be studies looking at hypomethylating agents in randomized trials. There is a large study looking at hypomethylating agents with venetoclax. So there will be emerging data coming out. The other off-label agent that we have been, I would say, a little bit disappointed with is lenalidomide, which is an immune stimulant, but it is associated with increased graft-versus-host disease. It has not been, the one thing is that in Brazil, you have access to drugs that are made in India and China, which many of them are much less expensive than the drugs that are being sold in the United States.
And talking about target agents, in Brazil you have only FLT3 agents, so you are doing the practical like Sorman or like Morpho? in United
So-
States.
I think Morpho was very, I think, instructive that only patients who were MRD positive before transplant benefited from gilteritinib post-transplant.
Okay.
Do you have access to sorafenib here? Is that what you have?
Not really. We are doing like midostaurin, like in the ratified trial, but the patients are consolidated with transplant, and if the patient using gilteritinib before, you continue with gilteritinib after the transplant, like the Admiral, the new data published. So sorafenib, we can do, but it's not approved in the scenario after transplant. It's only approved for oncological patients, so we have some issues to approve for insurance.
Right. Yeah. One other often neglected study, in my opinion, that was very positive, very scrutinized at the time, is a Chinese study that does decitabine combined with Neupogen or
Yeah.
GCSF. This was prospectively and showed a benefit of almost 20%, both in event-free and overall survival. And did never really get traction in the United States, or I believe not in Europe, but it should not be neglected
Yeah.
because it falls under this conversation about hypomethylating
Yeah.
agents. And so I always remind people, I don't remember the first author, but was published in JCO probably 4 years ago,
Yeah.
maybe. Yeah. Yep.
You have a few experience with this protocol now in consolidated patients. So I think now you have 4 or 5 patients in this model. So
Yeah,
let's
I think it's important because again, it's not as expensive, right? It's a decitabine. It's relatively less expensive than everything else. Anyways, yeah.
And for my final question, I would like to know what the patient that you are not indicated transplant in this scenario. So we are talking about patient who has AML with not remission. So there is any kind of patient you are not indicated transplant for them.
So there was a very interesting meeting early in this meeting about palliative care and involving the palliative care services early on. Anybody with a poor performance status, we should not be considering transplant, and we should be considering changing goals of treatment and giving palliative care. And then people with rapidly progressive
Yeah.
disease, the transplant also generally does not work.
Yeah, I was about to say it's hard to convey the message about disease tempo in these studies, but clearly when you see a patient whose doubling time is 48 hours, the likelihood that you're going to help him or her is dismal, right? I mean,
Leukemia burden makes a difference. You might have you can have active leukemia with 10% cellularity and active leukemia with 70% cellularity. Those are two different diseases.
Okay.
so yeah, I think
And-
I would agree 100%.
And CNS involvement with it's very
If we
in
clear
com-
it, we would. If we can clear it, we proceed.
okay.
Well, same. Surprisingly, not as bad as it
Yeah,
sounds.
yeah.
I mean, it's as long as you clear. But with active CNS, if it is a refractory, then I think it's a no.
It's my question with
Refractory CNS, you may have the occasional survivor with consolidation radiation to the brain, but you fall here in everybody will have a case report, or whatever, but everybody tends to forget the 50 times
The
you
50
tried
times
and
it didn't work.
it never worked. It's like, oh, look, I have one. I say, sure.
So thank you so much. Such an honor have this talking with both of you.